patients beyond 6 hours. In DAWN, it was up to 24 hours, 6 to 24 hours. In diffuse 3, it was 6 to 16 hours. The NIHSS for DAWN was 10 or more, and for diffuse 3, it was 6 or more. The baseline MRS for patients who presented to DAWN were 1 or less, and the baseline for diffuse 3 was 2 or less. The occlusion of patient selection criteria for DAWN was intracranial ICA stenosis or M1 segment stenosis, whereas in diffuse 3, it was cervical as well as intracranial ICA with or without a tandem MCA lesion with the M1 segment of MCA. DAWN used CT perfusion or DWI MRI to select their patients. They used an age-adjusted NIHSS with an age-adjusted infarct core size. Whereas in diffuse 3, they used a CT or MRI, and they also looked at the perfusion core mismatch. So we look at the results for DAWN. The patients who underwent EVT did much better than the patients who did not, and this was true through all the subgroups. And then if you look at diffuse 3, again, these results were replicated, and again, across all subgroups, thrombectomy was better. But what is most astounding really is that in DAWN trial, the numbers needed to treat is as low as 2.8. So that's quite remarkable. So as a result of these two trials, they made their way into the 2019 guidelines. Yeah? So a lot of what I'm going to talk about are things that have influenced our management of stroke neurology. So in the 2019 update of the 2018 guidelines, it says that in selected patients with acute ischemic stroke within 6 to 16 hours of last known normal who have large vessel occlusion in the anterior circulation and meet other DAWN or diffuse 3 eligibility criteria, mechanical thrombectomy is recommended. And then in selected patients within 16 to 24 hours of last known normal who have LVO in the anterior circulation and meet the DAWN eligibility criteria, then again, thrombectomy is reasonable. So they have to fulfill the criteria for these specific studies for their specific timeframes. So the other challenge with stroke neurology is wake-up strokes. So when we actually don't know when they were last well. And two studies actually were published, the wake-up study and the extend study. Okay. Wake up and extend. Wake up recruited about 503, extend 200 plus. This. Last known well is more than 4.5 hours. For wake up, there was no upper limit, but for extend, they had a 9-hour limit or midpoint of sleep of 9 hours or less. In wake up, they used an MR-DWI flare mismatch. Now the MR-DWI flare is quite accurate to pick up early strokes within 4.5 to 6 hours. So that's what wake up used. Extend used CT or MRI, but they used a rapid software to calculate salvageable tissue. They both compared TPA to placebo, so this is IV, and they were both terminated early, wake up due to funding, and extend due to wake up being published. When we look at the results of wake up, alter place, TPA, versus placebo in patients with wake-up strokes, we found that they did much better at 90 days with a symptomatic intracerebral hemorrhage rate of 6% versus 1% in placebo. And in the extend, what you see a similar pattern and symptomatic intracerebral hemorrhage rates were similar. So there was some criticism with extend. One, because it was terminated early. Two, there were some issues with statistical analysis. So extend didn't make it into the guidelines, but wake up did. So as a result of wake up, we find that patients eligible for IV alteplase, this is for scanning, yeah? Because benefit of therapy is time dependent, treatment should be initiated as quickly as possible and not delayed for additional multimodal CT. So basically what they're saying here, if the patients come within time, within the window, there's no need to waste your time with a lot of advanced imaging, just thrombolyze. And this is where Wake Up comes in. If they present at unclear time of onset, more than 4.5 hours, you have an MRI, you can do a DWI flare, and then you can, it is recommended that you thrombolyze. So we now thrombolyze Wake Up strokes based on these criteria. Okay, I think the three main principles of acute stroke management is one, to recanalize the occluded artery as soon as possible and reperfuse the ischemic tissue. That's number one. Number two, you want to optimize collateral flow. Number three, you want to avoid secondary brain injury. So I've already spoken about IV and mechanical for recanalization of occluded vessels. Now I'm going to talk about optimizing collateral flow. So a lot of ideas, suggestions on how to optimize, but basically what people do is they try to prevent drops of BP, they might give IV, they might allow some hypertension, permissive hypertension. And then there was a suggestion of head positioning for maintaining collaterals. There were small studies that suggested this was helpful, but this study, the head post study, actually looked at patients post-stroke onset, lying flat position for 24 hours versus sitting up at 30 degrees for 24 hours. And what they found was that there was no significant difference in 90-day outcome, mortality, or complications. So there was no benefit, basically. And also, it was harder for patients to keep patients flat for 24 hours than the patients at 30 degrees. So as a result of this neutral trial, the 2019 update states that the benefit is uncertain. Okay. Okay, about maybe 1/6, 15% of strokes are labeled as cryptogenic strokes. So cryptogenic strokes are strokes that after extensive investigation, you can't find the source. And it is thought that most of them probably have atrial fibrillation that have not been detected. So how do we effectively detect atrial fibrillation? There are two studies, EMBRACE and Crystal AF. EMBRACE stands for Event Monitor Belt for recording atrial fibrillation after a cerebral ischemic event. They recruited patients aged 55 and older who had suffered a cryptogenic TIA or stroke in the last 6 months, but who had no evidence of atrial fibrillation on 24-hour telemetry. So what they did was they divided the patients into an extended 30-day ECG monitoring and a 24-hour Holter monitoring. And the outcome they were looking for is a 30-second run minimum of atrial fibrillation or flutter. And what they found was in the 30-day ECG monitoring, they picked up 16.1% of paroxysmal atrial fibrillation compared to only 3.2% in the Holter monitoring cohort. And the numbers needed to screen were 8. And they also showed that the longer the yield, the longer the imaging or the testing, the greater the yield of picking up atrial fibrillation. And that translated to more patients being anticoagulated. Now, unfortunately, there was another study, Crystal AF, cryptogenic stroke and underlying atrial fibrillation. So this is also looking for detection of AF. And they actually recruited patients aged older than 40 who suffered a cryptogenic TIA or stroke within the last 90 days. And they compared insertable or implantable cardiac monitor with conventional ECG, Holter, echo, vessel imaging, thrombophilic screen. They were looking for an outcome similarly of a 30-second minimum run of atrial fibrillation. They also looked at stroke or TIA recurrence and anticoagulation rate in 12 months. And what they found was that the implantable cardiac monitor was more sensitive to picking up paroxysmal atrial fibrillation. However, these trials were targeted for picking up atrial fibrillation. Their secondary outcome was patient outcome. So they didn't design it for patient outcome, and therefore it wasn't powered enough for that. So as a result, the 2019 update of the 2018 guidelines says that the effectiveness of prolonged cardiac monitoring during hospitalization after acute ischemic stroke to guide treatment selection for prevention of recurrent stroke is uncertain. Okay, so up to now, I think the only agent used for IV thrombolysis is alteplase or TPA. Tenecteplase has been used in the heart for a long time. Very attractive because it's fibrin specific, is a longer half-life. You can give it in a single bolus. You don't have that 1 hour infusion of alteplase. So tenecteplase has been investigated in stroke. The initial study was called the NOR-TEST study, and they showed that actually there was no difference between, the outcome was the same. We used tenecteplase or alteplase. But again, in this study, they actually, they were looking for superiority, so they couldn't actually conclude that alteplase and tenecteplase were equivalent in terms of efficacy. That was until this trial came out or published in 2018, which was Extend IA-TNK, tenecteplase versus alteplase before thrombectomy for ischemic stroke. There were 2 parts. This was part 1, and part 2 was looking at the dose. So if you look at part 1, what they did was they recruited all acute ischemic strokes who presented within 4.5 hours, which means they're eligible for IV, who had large vessel occlusion on CT, either ICA, MCA, or basilar. So they recruited anterior as well as posterior circulation. They randomized the patient to receive either tenecteplase, 0.25 milligrams per kilogram, or alteplase, standard dose of 0.9 milligrams per kilogram, followed by endovascular therapy. And what they found was that tenecteplase, in tenecteplase group, the patients had a better functional outcome than the alteplase group. The second part of the Extend IA-TNK recruited patients mostly in Australia and New Zealand. It was only to look at the efficacy of the 2 doses, 0.4, which is a higher dose, milligrams per kilogram, versus 0.25. And they also look at reperfusion rate. And what they found that there was no difference in patient outcome or reperfusion of the ischemic bed. So they concluded that there was no advantage of the higher dose. So as a result of that, tenecteplase has finally made it into the guidelines. The 2019 update states that it may be reasonable to choose tenecteplase, a single bolus of 0.25 milligrams per kilogram, over alteplase in patients without contraindications for IV fibrinolysis who are also eligible to undergo mechanical thrombectomy. And it states here that 0.4 was not superior, nor was it non-inferior to alteplase. Okay, so that's the first part on acute management of acute ischemic stroke. Now I'm going to go on to secondary prevention of stroke. I'm going to talk about antiplatelets, anticoagulation, and BP control. This is my pet topic, and I always tell the MOs, the registrars, TIA is your perfect opportunity for secondary prevention. Okay, so it's not just a TIA, it is your perfect opportunity. Okay, and the reason is because if you looked at this study, it's quite an old study, 2000. They actually recruited patients who presented to ED with TIA, followed them through for 90 days, and they looked at the stroke events. And you see that the stroke event was about 10.5%. So 10.5% of patients returned with a stroke. And if you look, especially within the first 7 days or 48 hours. And this other graph just shows you that as you go down the graph, you see that the more the more risk factors the patient had, the higher they were likely to return with a stroke. If you look at the table on your right, you see that 5 independent risk factors have been identified for patients who have a TIA who are at high risk of stroke. And they are if they're over the age of 60, if they had diabetes, if the duration of that TIA episode was more than 10 minutes, or if they had weakness or speech difficulties during that TIA episode. So TIAs are very important. Which brings me to this study, these two studies looking at antiplatelet therapy. Chance and Point, I'm sure you've heard of them before, and they were looking at dual antiplatelet therapy. So let's look at them together, as I like to do them. So Chance, they recruited patients with minor stroke, defined as an NIHSS of 3 or less, high-risk TIA of ABCD score, ABCD2 score of 4 or more. They gave dual antiplatelet, which was aspirin and clopidogrel, in the first 24 hours for 21 days, followed by a single antiplatelet, which was aspirin. And what this group found was that there was reduced 90-day stroke in the DAPT group and no increased bleeding. So this was primarily in China. And so the North Americans and the Europeans were a little bit critical of the results. One, because they thought the Chinese population had a lot of uncontrolled comorbidities, and two, because they had polymorphism, they also had a lot more of intracranial arterial disease. So they designed a study very close to Chance. Their selection criteria was similar, NIHSS and ABCD2 score. They also gave a dual antiplatelet, aspirin and clopidogrel, but they gave them within 12 hours of symptom onset. And the single antiplatelet that they followed through with was clopidogrel. And they also found reduced rate of stroke, but an increased bleeding rate as well. So as a result of these two trials, antiplatelet therapy for minor non-cardioembolic ischemic stroke, non-cardioembolic, because cardioembolic.
Hi, my name is Abdullah.